my name is Teresa Kachinos, and I'm currently a student in the Master's of Science in Applied Nutrition program at the University of New England. Today I'm going to be introducing you to non-alcoholic fatty liver disease, vitamin E, and the results of a systematic review on the literature discussing these two topics. Non-alcoholic fatty liver disease, or NAFLD, is a term that covers a spectrum of liver diseases caused by the accumulation of fat droplets in the hepatocytes. While the degree of fat accumulation can range from steatosis to steatohepatitis, untreated NAFLD can lead to fibrosis, liver cirrhosis, and hepatocellular carcinoma. There are many potential causes for NAFLD, including drugs, inborn errors of metabolism, and acquired metabolic disorders such as type 2 diabetes mellitus, jejunal ileal bypass, obesity, and malnutrition. This condition is most commonly associated with obesity, diabetes mellitus, dyslipidemia, and insulin resistance. It is important to note that NAFLD is the onset of accumulation of fat droplets in the hepatocytes without the intake of alcohol. Hepatic steatosis, the accumulation of fat in the hepatocytes, is caused by the culmination of these metabolic disturbances: an increased mobilization of fatty acids from the adipose tissue, an increase in hepatic synthesis of fatty acids, a decrease in fatty acid oxidation, an increase in triglyceride production, and finally the trapping of triglycerides in the liver. Patients with NAFLD generally experience no symptoms, although there may become upper right quadrant abdominal discomfort. NAFLD is generally only discovered if there are complications as the disease progresses to non-alcoholic steatohepatitis, which we'll discuss in just a moment, liver cirrhosis, or hepatocellular carcinoma. While we will not be focusing on non-alcoholic steatohepatitis, or NASH, for this presentation, it is important to note that NASH is the progression of NAFLD, which is characterized by the accumulation of fibrous tissue in the liver. While not all NAFLD patients progress to NASH, those who do can remain symptomatic. Those who experience symptoms may not identify them: malaise, weakness, and hepatomegaly, or an enlarged liver. The treatment of NASH is gradual weight loss, the potential use of insulin-sensitizing drugs like metformin, and the treatment of dyslipidemia. Extreme rapid weight loss can accelerate NASH, which can encourage the development of cirrhosis and increase the incidence of gallstone development. Outside of rapid weight loss, the progression of cirrhosis is variable depending on age and the presence of obesity and type 2 diabetes. Non-alcoholic fatty liver disease affects somewhere between 20 to 30% of the general population in the Western world. There is a very strong associated increase in the prevalence of NAFLD in patients with type 2 diabetes mellitus and those who are morbidly obese. This increase and the increased prevalence of NAFLD is correlated with the increased prevalence of both obesity and type 2 diabetes mellitus. In Asia, NAFLD affects 15 to 30% of the general population, although in patients with metabolic syndrome and diabetes, this statistic jumps to over 50%. In the general population in the United States, the prevalence of NASH is about 3%, but could be more than 25% in obese individuals. Vitamin and mineral deficiencies can occur as the result of the alteration in absorption, storage, and ability to convert nutrients to their active forms. Steatorrhea, caused by bile acid deficiency, is also common and it affects the body's ability to absorb fat-soluble vitamins. Vitamin A deficiency can lead to night blindness. However, all B vitamins as well as vitamins C, D, E, and K are also commonly deficient in these patients. This systematic review will look at NAFLD in adults. So in adults with NAFLD, what are the effects of vitamin E on ALT, AST, and liver fibrosis? ALT, or aminotransferase, is located in the cytosol of the hepatocyte, but is also found in other body tissues, and it is highest in the liver. An increase in ALT indicates liver cell damage. AST, or aspartate aminotransferase, is located in the cytosol and mitochondria of the hepatocyte. It is also in cardiac, skeletal muscle, brain, pancreas, kidney, and leukocytes. An increase in AST generally indicates liver cell damage. Liver fibrosis is the measured amount of inflammation and scarring that occurs in liver damage. As part of a systematic review, both PubMed and ProQuest databases were searched using the combination of the words non-alcoholic fatty liver disease, NAFLD, vitamin E, tocopherols, and tocotrienols. There were 39 articles identified through database searching. All 96 were screened and 6 were identified for full-text assessment. After a full-text assessment, 4 were included for qualitative synthesis. 1 was excluded for being non-alcoholic steatohepatitis, and 1 was excluded as it was utilizing data gathered in an already included study. The 4 articles included in the qualitative analysis we will be discussing further but are listed here. The first study we're going to discuss is Parika et al. The purpose of this study was to compare the efficacy of vitamin A versus UCDA, or ursodeoxycholic acid, in non-diabetic, non-alcoholic fatty liver disease patients. This study was a prospective single-center, open-labeled, randomized control that took place in India from December 2011 to December 2013. There were 250 subjects enrolled in this study. This study required that subjects be 18 to 80 years old with non-alcoholic fatty liver disease that was diagnosed by ultrasound. Patients also had to have an ALT or AST greater than the upper limit, which is greater than or equal to 40 IU per milliliter. Patients were excluded if there was a history of alcohol intake greater than 20 grams per day during the previous 5 years, hepatitis B antigen reactive, the presence of antibody antigens for hepatitis C, if they were HIV reactive, they had active hepatitis, a biliary obstruction on the ultrasound, if they were diagnosed with cirrhosis at any previous point in time, if they had tuberculosis, malabsorption, chronic drug use, if they were pregnant, or had any cardiorespiratory comorbidities. All patients were advised and monitored by a dietitian for dietary and lifestyle modifications to lose 5% body weight and maintain the weight loss. Subjects were divided into 2 groups. Group A received 400 IU 2 times daily of vitamin E, and Group B received 300 milligrams of UCDA 2 times daily. Subjects were assessed at 8, 16, 24, 36, and 52 weeks for a CBC, serum transaminase, creatinine, and triglycerides, as well as a cholesterol count and fasting blood glucose. A fibroscan was done to assess liver fibrosis at baseline and 52 weeks. This chart illustrates ALT at baseline, 24, and 52 weeks in both treatment groups. The change in ALT from baseline to week 24 and 52 is significant, although the difference between 24 and 52 weeks is not. AST at baseline, 24, and 52 weeks for both treatment groups is pictured. The change in AST from baseline to 24 and 52 weeks is significant. However, the change from 24 to 52 weeks is not. This final figure shows the fibroscan results at baseline and 52 weeks. There is a significant improvement in both groups from baseline to 52 weeks. Based on these results, we can conclude that UCDA is as effective as vitamin E in Indian patients when combined with adequate dietary guidance and lifestyle modifications. The next study we're going to look at is Kim et al., which examined the short-term effects of vitamin E in NAFLD patients with metabolic syndrome. This was a retrospective cohort that examined 116 subjects. All subject data was pulled from May 2003 to December 2013 at the Seoul National University Bundang Hospital. Patients were included if they were 18 years or older with a diagnosis of NAFLD and an AST greater than or equal to 40 IU per liter, with the qualifying signs of metabolic syndrome. Patients were excluded if they had other causes of steatosis like alcohol intake, other causes of ALT elevation like viral hepatitis, autoimmune liver diseases, toxic hepatitis, or hemochromatosis, and a comorbidity like advanced malignant diseases, or if the patient took a multivitamin prior to enrolling in the study. Patients were either in the control group with no vitamin E supplementation, N equals 250, or the treatment group, N equals 85. The treatment group, on average, had a supplementation of 883 IU per day, and it had a mean duration of 182 days of taking the supplement. AST, ALT, total bilirubin, cholesterol, triglycerides, HDL, and LDL were assessed at baseline and every 3 months. 58 patients from each group were matched via propensity score for age, sex, BMI, ALT, AST, diabetes mellitus, and dyslipidemia. The chart on the left illustrates the change in AST and ALT from baseline over 6 months. There was a significant change in both ALT and AST. The chart to the right details a change in AST and ALT with differing vitamin E dosages. Based on this information, researchers concluded that short-term vitamin E treatment improves abnormal liver enzymes in adult NAFLD patients with metabolic syndrome. Our next study evaluated the impact of tocotrienols in normalizing hepatic echogenic response in adults with NAFLD and hypercholesteremia. This study was a parallel, double-blinded, placebo-controlled study that enrolled 87 participants from February 2008 to January 2009 in Malaysia. Participants were included if they were 35 years or older with ultrasound-proven NAFLD and a total cholesterol of 200 to 240 milligrams per deciliter and an LDL of 100 to 161 milligrams per deciliter. Participants were excluded if they had an alcohol intake greater than 20 grams per day, if they had any anti-hyperlipidemic treatment, vitamin E supplementation, if they had any previous cardiac events, or acute hepatitis. Patients were randomly assigned to either the control or treatment groups for 1 year. The treatment group received mixed tocotrienols at 200 milligrams 2 times daily. Every 3 months, a fasting blood sample was taken to measure serum total cholesterol, LDL, HDL, triglycerides, apolipoprotein B, lipoprotein A, high-sensitivity C-reactive protein, fasting blood glucose, ALP, AST, and ALT. This chart illustrates ALT and AST along with other lab values. We can see changes from baseline to post-intervention in both treatment and control groups. If you look, there was no significant changes in AST and ALT. While researchers were able to conclude that patient in the mixed tocotrienols group at 200 milligrams 2 times daily normalized the echogenic response in NAFLD compared to control. However, we can also conclude that there were no significant changes in ALT or AST from treatment to control groups. The final study we're going to discuss is Say Not at All, which examined the efficacy of pioquidolazone versus vitamin E and placebo in adult patients with NAFLD. This was a parallel randomized control trial that enrolled 247 individuals. Prior to randomization and intervention, patients had a liver biopsy in which steatosis, lobular inflammation, and hepatocellular ballooning were each measured on a scale of 1 to 4. Patients were included in the study if they had a score of 5 or more. Patients could not have diabetes, and alcohol consumption greater than 20 grams a day for women or 30 grams a day for men. They could also not have cirrhosis, hepatitis, or heart failure. Participants were then randomly assigned into 3 groups: placebo, N equals 83, Vitamin E, N equals 84, where participants received 800 IU of vitamin E per day, or pioquidazole at 30 milligrams a day, N equals 80. At baseline, 96 weeks, and various weeks throughout the study, patients had height, weight, waist and hip circumference, and then blood samples were taken to measure fasting lipids, fasting glucose, and fasting insulin levels. Patients also received a liver biopsy at the completion of the treatment as well as at baseline. In each group, fibrosis was measured at both baseline and at follow-up. As marked on this chart, there was no significant difference between liver fibrosis and vitamin E versus placebo patients. However, we can see that vitamin E subjects saw massive decreases in both ALT and AST levels versus placebo over the course of the study. If you notice the slight uptick at the end of the chart, that is due to the fact that researchers followed the test subjects 25 weeks post-intervention to see if there were any changes. We can see that after the introduction, there was a decrease, and after the cessation of supplementation, there was an increase in AST and ALT levels. Based on this information, we can conclude that vitamin E supplementation in adult NAFLD patients will decrease ALT and AST, but it does not improve liver fibrosis. Now that we've reviewed each of these studies, we can look at the results of the studies side by side. So our first study came to the conclusion that vitamin E is effective in decreasing ALT and AST and liver fibrosis in Indian patients when combined with dietary and lifestyle modifications, guidance, and monitoring. Our next study looked at short-term, which is 6-month supplementation of vitamin E, and they saw that it improves ALT and AST in adults with metabolic syndrome. However, when we looked at patients who received mixed tocotrienols, we saw no improvements in ALT and AST. Then we looked at vitamin E compared to a placebo. While it may not have any effect on liver fibrosis, we can see that it does improve both AST and ALT. We can now look at what the clinical implications of these findings are. We found that in adult patients with non-alcoholic fatty liver disease, vitamin E supplementation, when paired with rate reduction and maintenance that is monitored by a dietitian, can see improvements in ALT, AST, and liver fibrosis. Therefore, we can recommend vitamin E supplementation and that it should be considered in adult patients with NAFLD who have high ALT and AST levels and are looking to improve those.